were so many amazing presentations at ASCO GU this year, but I'm going to focus on a topic that's often overlooked and underrepresented, which is that of healthcare access and equity, specifically as it relates to prostate cancer. So we know that prostate cancer is the most common cancer in men in the United States. We also know that there are differences depending on rural, metropolitan, or urban demographics in patient characteristics, their clinical presentation, treatment patterns, and eventually cancer-related outcomes. So in this study, Nicholas Stabilini and Avareep Guha from Augusta University presented this very topic in Abstract 265. Introduced was this intriguing concept called rurality and how it applies to both the patient and providers of that demographic, and ultimately the outcomes. In this case, a rural area or rurality is defined as areas with fewer than 20,000 people who are not adjacent to metropolitan areas. This group then reviewed the SEER Medicare database from 2009 to 17 for males more than 66 years old with a new prostate cancer diagnosis. Lastly, the authors specifically tried to quantify cardiovascular and cancer mortality outcomes. So in this retrospective review of over 75,000 patients with a median age of 72 years, it was found that more than 95% of those patients were participating from metropolitan or urban areas and with the providers in the same locations. Only 0.8%, or about 600, were rural patients with metropolitan providers, or 0.5%, which is about 375 patients, in rural patients served by non-metropolitan providers. So it was no small task in this group's attempt to deduce patterns by dividing up patients' outcomes depending on whether the patient or provider were from an urban or metropolitan area, urban area getting care in a rural area, or vice versa. And ultimately, what they found was that all-cause mortality was 44% higher and cardiac mortality 33% higher in patients from rural areas with non-metropolitan providers. And I won't go into it in detail in this video, but another study in the same poster session by Dr. Hugh from Huntsman Cancer Institute in Utah confirmed a very similar trend in a study of all-cause and prostate cancer-specific mortality in rural areas there. So there were some key limitations in this analysis. Firstly, it was a retrospective analysis. Also, it concluded in 2017, which is not that long ago, but certainly so many new treatments and technologies have emerged since then. It'd be interesting to see how COVID in 2020 and the current post-COVID era has impacted rurality. The geographical region that was defined was a very specific area of Georgia in this study, and it wasn't the entire U.S. Also, the definition of rural area was not arbitrary, but certainly one that's difficult to define depending on where you go. For example, how do we define suburbs? And then one of the biggest limitations, which also underscores, I think, the main point here, is that the target population was highly underrepresented, basically 0.5% of the total population. So this alone underscores how important it is to enroll patients from diverse socioeconomic and geographic populations in clinical analyses and clinical trials, and how hard it is to do that, to be honest. So further parameters definitely need to be teased out from this analysis and future ones, including how to understand factors leading to these outcomes in rural populations. This could include things like underlying baseline health or comorbidities, ethnicity, belief system, diet and BMI, family history of cancer, income status, and maybe type of employment, proximity of the community or that employment to potential environmental hazards or exposures, insurance status, stage of diagnosis, and whether disease was detected early as compared to advanced, and even the length of time from diagnosis to referral to effective treatment rendered. Ultimately, I hope we can all say this is just how important it is to recognize the issue of rurality, its impact on cancer outcomes, not just in prostate cancer, but likely in every type of cancer. Studies like this show that rural resident status has a major impact on cancer care, and it's a key socioeconomic determinant of outcomes. So how do we improve from here? I think to improve on this, we need to not only focus on further analysis and recognize nuanced population parameters, as I sort of defined above, but also to increase enrollment of this vulnerable population into trials and to design interventions to mitigate rural-urban disparities by increasing access to quality, time-sensitive, compassionate care. Thank you very much.